In my job, I meet people on the worst day of their life. I'm an intensivist, a physician who specializes in intensive care medicine. If you become my patient, it's because you need life-sustaining therapies in the ICU. Lately, I've been rethinking how I care for people. Let me tell you why. On February 27, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, two buses collided head-on. This is what was left of one of the buses. 6 people died, but miraculously, 56 people were saved. 5 years later, researchers asked the question, what do survivors remember? They interviewed every survivor, and using a rigorous qualitative research methodology, they found 2 common themes in the data. The first was expected, the physical pain that they felt at the moment of impact. But the other theme? A lack of compassion from the caregivers at all the hospitals. That's what they remembered 5 years later. These data have begun to open my eyes to a stark reality. In healthcare, we are in the midst of a compassion crisis. Scientists define compassion as an emotional response to another's pain or suffering involving an authentic desire to help. It's different from sympathy or empathy, which are the feeling and understanding components, in that compassion also involves taking action. So here are the data. Research from Harvard University found that nearly 50% of Americans believe that our healthcare system and our providers are not compassionate. 2/3 of patients have had a meaningful healthcare experience with a lack of compassion. Rigorous research show that 70% of opportunities for compassion are missed by physicians, and compassion comprises less than 1% of all communications by physicians to patients. These data are compounded by an epidemic of burnout in healthcare providers. Burnout is characterized by depersonalization, which is an inability to make a personal connection. And in the era of electronic medical records, rigorous research shows that healthcare providers spend more time looking into computer screens than looking patients in the eyes. Based on all of these data, I conclude we have a compassion crisis indeed. But here's the big question. Does it matter? Does compassion really matter? Now, you may say, of course compassion matters. We have a moral imperative. It's part of the art of medicine. And of course, I agree. But is compassion just in the art of medicine? Or are there also evidence-based effects belonging in the science of medicine? And what is the evidence? In addition to being an intensivist, I'm also a physician scientist. In other words, I'm a research nerd. I like data, and my hypothesis was that compassion matters for patients, for patient care, and for those who care for patients. So I went to the biomedical literature, and I used a methodology called systematic review. So over 2 years through the National Library of Medicine, I reviewed more than 1,000 scientific abstracts, more than 200 research studies in total. And today I share with you what I found. The effects of compassion on patients, on patient care, and specifically the costs of care, and on those who care for patients, our healthcare providers. There are more than 20 distinct mechanisms of action by which compassion can have beneficial effects on patients. Let's go to the data. Let's start with the practical. If you have compassion for patients, you may be more likely to be meticulous about their care, or have higher quality standards, and lower likelihood of making a major medical error. But there are also physiological effects. Compassion can buffer stress-mediated disease. Compassion can also modulate a patient's experience of pain. There are neuroendocrine effects. So in patients with diabetes, research shows that high physician compassion is associated with an 80% higher odds of optimal blood sugar control and 40% lower odds of acute metabolic complications. There are also immune system effects. So in a University of Wisconsin study in patients with the common cold, High physician compassion, as rated by patients, was associated with enhanced immune response, shorter duration of symptoms, and lower severity of symptoms. And importantly, compassion can impact patient self-care. If you care deeply about patients, and they know that, they may be more likely to take their medicine. In a Johns Hopkins study of 1,700 patients with HIV, researchers asked patients, does your physician know you as a person? Knowing the patient as a person was associated with 33% higher odds of adherence to therapy and 20% higher odds of having no detectable virus in the blood. Compassion has also been associated with lower healthcare costs, which are a major factor in the health of our economy. In primary care, for example, research from the University of Rochester and UC Davis have shown that compassionate, patient-centered care is associated with lower discretionary resource utilization. So fewer diagnostic tests, fewer referrals to specialists, fewer unnecessary hospitalizations, and lower total healthcare charges. So here's the bottom line. If healthcare providers actually spend more time talking to patients, maybe we don't need so many tests and referrals. But what about time? We've all heard the expression, time is money, but time is also a vital factor in the efficiency and the economics of healthcare. So here's a staggering number, 56. Research from Harvard University shows that 56% of physicians believe they do not have time for compassion. This is in the context of a classic study from Princeton University on helping behaviors, which found that it wasn't the intrinsic belief of the importance of helping by the potential helper. It was whether or not the potential helper believed they had enough time to help. So how long does it actually take for a meaningful expression of compassion? To address this, researchers from Johns Hopkins University did a randomized controlled trial in patients with cancer who were having a consultation with the oncologist. And in this randomized trial, the primary outcome measure was anxiety. And if you have cancer, that's a pretty important outcome measure. So they found that patients randomized to a compassion intervention from the oncologist had less anxiety than usual care. So what was the compassion intervention? I could describe it for you, but instead I'm just going to read it to you. From the oncologist at the beginning of the consultation. I know this is a tough experience to go through, and I want you to know that I am here with you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me. If something I say is confusing or doesn't make sense, we are here together and we will go through this together. And at the end of the consultation, the oncologist said, I know this is a tough time for you, and I want to emphasize again that we are in this together. I will be with you each step along the way. So how long did that take? They timed it 40 seconds. So this randomized trial shows that all you need is 40 seconds of compassion to make a meaningful difference. Importantly, 40 seconds of compassion can be a powerful therapy for the giver too. And this is important because these data are not just applicable to healthcare workers, but to everyone here today. Science shows that compassion for others can have a direct, positive effect on your own well-being. Neuroscience studies show that compassion for others can trigger reward pathways in the brain and positive emotion that can buffer or even counteract the activation of stress pathways and negative emotion. So, in effect, compassion for others can make you forget your own worries, at least temporarily. So now this is where the science meets the personal. A couple of years ago, after nearly 20 years of working in the ICU and meeting people on the worst day of their life, I came to a stark realization. I had almost every symptom of burnout. And let me assure you, that's not a good place to be. It can be a dark place. Currently, the recommended prescription for burnout is what I call escapism. Get away, detach, pull back, go on some nature hikes or whatever. But I was not buying it because I believed that the antidote to burnout had to be at the point of care, in personal connection, human connection, not an escape. So what was I supposed to do? Well, I did the only thing I knew how to do. I took the research nerd approach. And armed with the data that 40 seconds of compassion can be a powerful therapy for the giver too, I decided to do an experiment on myself. I was the only research subject in this experiment. I was the N of one. So I tested the hypothesis that my 40 seconds of compassion would transform my experience. I connected more, not less. Cared more, not less. Leaned in rather than pulling back. And that was when the fog of burnout began to lift. My 40 seconds of compassion changed everything for me. Now, you might be thinking, I'm speaking on the power of compassion. I must be the most compassionate doctor. But the truth, if I'm being honest, is that I'm still a work in progress. I'm working hard at compassion every day, but I see it now. And thankfully, science shows that change can happen. I used to think that people were either wired for compassion or they were not. But the preponderance of evidence in the scientific literature, both in healthcare workers and in the general population, shows quite clearly that compassionate behaviors can, in fact, be learned. And that is good news indeed. So now it's time to answer the big question that I posed to you at the beginning. Does compassion matter? My systematic review of the literature now complete. 1,000 scientific abstracts, 200 research manuscripts, and one life-changing N of one experiment behind me. I now conclude with confidence. Compassion matters. For patients, for patient care, and for those who care for patients. Compassionate care belongs in the domain of evidence-based medicine. I no longer believe in this paradigm behind me, this historical paradigm. I now believe in this one. Because I found that there is science in the art of medicine, and the science is strong. I like to call this field compassionomics. It's the convergence of the science and the art of medicine. I will close just by acknowledging that you don't have to be a healthcare worker to feel burned out. And if you do, I suggest that you test the compassion hypothesis for yourself. Do your N of one experiment. Look and see those around you in need of compassion and give them your 40 seconds of compassion. See how it transforms your experience. But don't do it because I say so. Do it because science says so. 40 seconds of compassion can change everything for a patient. It changed everything for me. It can change everything for you too. And that is the power of 40 seconds. Thank you.
So as Tom mentioned, I'm an intensivist. A lot of people didn't know what that was before the COVID pandemic. And then people said to me, oh, you're one of those people. Let me tell you, the last few years has been a really interesting time to be an intensivist, a specialist in intensive care medicine. I'm not going to talk about the pandemic today, but we often did and have always met people on what they might describe as the worst day of their life. And that's a unique vantage point, no doubt. But there are a lot of principles that I've gleaned from that experience that I think are applicable to everybody, everywhere. And so for the first 15 years of my career, I was doing resuscitation science in the ICU. My colleagues and I were research nerds, and we had NIH grants. We were publishing in some of the best journals. Our work was being disseminated in our field and getting a lot of notoriety. Like, everything was going as planned. What we were trying to do is find the optimal level, and we had an NIH grant to do this, the optimal level of oxygen in the blood to reduce the risk of permanent brain damage after somebody's resuscitated from cardiac arrest. And now I study compassion science and serving others. And so I need you to know I was not in the market, and Tom could attest to this, I was not in the market for any kind of change in trajectory for my life, for my research career, for my career in general. But then an unexpected question from a 12-year-old turned everything upside down and literally made me change the trajectory of my life's work. So that 12-year-old was my son. One night when we were at home, he asked me a question. He said, "Dad, I know you give a lot of talks in your research. I have to give a talk for my class at school. Can you help me prepare mine?" And I thought, this is going to be totally awesome. What an amazing father-son bonding opportunity. Little did I know what was in store for me. So I said, "What you got?" And he reaches into his backpack and he puts the sheet of paper down on my desk. And on the sheet of paper was the topic for his talk at school. The question was this: what is the most pressing problem of our time? 7th grade. I don't know what you all were doing in 7th grade. I was not doing what's the most pressing problem of our time. I was a little bit blown away, and what he picked isn't what's important. What's important is that he actually believed it, so that he would give a talk that not only his classmates would find compelling, but he would too. And what we came to over the next few nights of discussing with my son, we realized there's no such thing. There's no one single most pressing problem of our time. The question is, what's the most pressing problem of our time for you, through your lens of experience, in your little corner of the world, or whatever scope of influence you might be able to have. And that led me on a great period of introspection. Some people, including my wife, would call it a midlife crisis. But I knew that the work that we were doing was important if you happened to have that sort of condition or disease process. Well, was it the most pressing problem of our time? And what would my life look like if I really believed that we were working on the most pressing problem of our time? Would I ever need an alarm clock ever again? And so before I tell you what it is, I'm going to tell you a story. So on February 27th, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, 2 buses collided head on. And now this is what was left of one of the buses. You could imagine the scene. The extrication of the victims was so complex that this case literally made its way into the annals of a disaster medicine textbook. 6 people died tragically, but somehow, 56 people were saved. 5 years later, researchers asked a question. What do survivors remember? What do survivors remember? They used a rigorous qualitative research methodology. They interviewed every survivor, and there were 2 common themes in the data. The first was totally expected. It was the physical pain that they felt at the moment of impact. But the other theme, it was unexpected. It was a lack of compassion from the caregivers at the hospital. Now, what's particularly striking about the research is when you read into the methods section of the paper and you realize that the victims were taken to multiple different trauma centers, yet they had the same experience. These data began to open my eyes to a harsh reality. In healthcare, we're in the midst of a compassion crisis. Now you may say, well, perhaps we just have a compassion crisis broadly in society. And there are data for that. So a University of Michigan meta-analysis found that over 2 decades, empathy among college students has been declining over time. And the speed of that decline is actually accelerating. A Harvard Graduate School of Education study of 10,000 youth in the US, middle school and high school students, found that 80% of our youth believe that their parents value their achievements and their accolades more than they value the kids' kindness for others. And in a striking Pew Research study from just a few years back, fully 1/3 of Americans surveyed endorsed that they don't consider compassion for others to be among their core values that describes them well. Now, healthcare is supposed to be different, and I could go through a mountain of evidence for you on a compassion crisis in healthcare, but I won't do that today. Rather, I'm just gonna pose a question to you. Why? Why is it that we have a compassion crisis? Why is it that we have an erosion of human connection? And the answer that I gave to over and over and over again is because everybody is burned out. Now, I want to acknowledge something super important, and I want to make it crystal clear. You don't have to be a healthcare worker to feel burned out. It just so happens that the healthcare community, the workers in the healthcare community, are a population you can get your arms around. So if you're a researcher, you can study that population quite easily. It's been equated with healthcare workers because that's just where the researchers have been doing the research. But there's nothing specific to putting on scrubs and going to a hospital in the morning. There's nothing specific to that as it relates to burnout. So burnout, among the scientists that study this, has 3 domains. The first is emotional exhaustion. The second is depersonalization. That's an inability to make personal connections. And the last one, the third one, is the feeling that no matter how hard you try, you're just not making a difference. And so this, for me, is where the science meets the personal. Because as I became aware of these data, and I knew that all of this was rooted in burnout, I became keenly aware that I had every symptom of burnout myself. Every single one. And without getting too personal, I will tell you that that is a dark place. It is real. It is no joke. But what was I supposed to do? Well, I'm a research nerd. So I didn't go to Google. I went to PubMed, which is like the Google for medical science. See, what Google would have told me is I should get away more, take more vacations, escape, if you will, right? Put on your headphones and block out the world. Take nature walks by yourself. That's what the conventional thinking has been for self-care, which we'll talk about in a little bit. And what I was taught, well, first of all, I wasn't buying it. I wasn't buying it that the cure for my burnout would be in escaping. First of all, not sustainable or practical, right? It's not like just getting away from my patients as much as possible is going to make everything magically better. And so what I did was I went to the medical science. Now, when I was in medical school, and we're talking about 1992, I was taught, literally taught. And when I talk to physicians, by the way, folks that have as much gray hair as I do nod like, yeah, I was taught that same thing. We were literally taught, don't care too much. Too much caring, too much compassion, that burns you out. And I believed that dogma for 25 years. I'm a physician scientist. I do research for a living, and I believed dogma for 25 years. And imagine my surprise when I opened up the medical literature and I looked into the science, and I found that where opinion once reigned back in 1992 and conjecture, Now it was filled with robust research. And what the research showed quite clearly is that there is an association between compassion and burnout, or caring and burnout, but it's inverse. It's inverse. So if what I was taught in medical school was true, too much caring burns you out, then you'd see high compassion, high burnout, low compassion, low burnout. But that's not what the evidence shows. The scientific evidence shows a different signal. It's inverse. High compassion, low burnout, low compassion, high burnout. Why? In the context of healthcare, if you care deeply about your patients and you get the relationship that flows from that, you get the good part about taking care of patients. You get the good part about being in medicine. And if you don't have that, all you have is a really stressful job. So, faced with this new information, I decided, and we wrote a book about it, by the way. It's called Compassionomics. It's more for healthcare folks. What the research showed is that compassion for others can be a powerful, beneficial therapy for the giver, too. For the giver, too. And so I did what I call my N of 1 experiment. And one study subject in this experiment, it was me. I decided I was going to connect more rather than detach and pull back. I was going to care more, not less. I was going to lean in rather than escape. And not just with my patients or their families in the ICU, but with the nurses that I'd worked with for like 15 years at that point, with my trainees, with my colleagues, even at home. And that's when the fog of burnout began to lift for me. And so we wrote a book about it, among other things. And we started getting these messages like, hey, I tested the compassion hypothesis for myself too when I was totally burned out. And I had the same experience. I feel a lot better. I'm working on all my relationships and human connection. And I want to make sure I say this right now so I don't forget to say it later. Between the last project and this project and 5 years of studying this, if there's one thing we have learned, Dr. Maz and I, through our research, it is this. The key to resilience is relationships. The key to resilience is relationships. That's not my opinion. It's not what I think or believe. I'm not preaching to anybody here, for sure. I'm just telling you what we found in our journey through the evidence. So we were getting all these messages that I tried this when I was in the throes of burnout, and it worked for me too. And I feel so much better. And Dr. Maz and I got to thinking, there is no way that this is only true for people who put on scrubs and go to work in a hospital every day. There's got to be some sort of common thread or universal. And so our approach is to look at familiar things in unfamiliar ways. So in our earlier work, it was specifically compassion in the context of healthcare. And now with our more recent project, it's not compassion for others, it's serving others. Another research term that's been put to this is pro-social behavior. That's just a research term for kindness. And so what we do is look at kindness, something that you're very familiar with, but we look at it in unfamiliar ways rather than looking at it through a moral, ethical lens or an emotional, sentimental lens. We've examined kindness through the lens of science. And so, again, what I share with you today isn't what I think or believe, and I'm definitely not preaching. It's just what we found, and we've got the receipts to prove it. 250 original science research papers. And so that's our approach. And in our last book, the question, the big question, I like big questions, by the way. Full disclosure, earlier in my life, in a moment of youth and indiscretion, I decided to become a philosophy major. I don't know why. Somehow I made it through the MCAT, but I like big questions. So the big question in our last effort was, does compassion really matter? Like, is it just cherry on top of the sundae if you're a doctor or a nurse? Or is it really integral to healing? And what is the evidence to prove it? So the question in this book, which is for everybody everywhere, not for healthcare workers, is what's the evidence-based way to live your life? Is it all about meism? Or is it to be other-focused in what we call a live-to-give approach? So back in what some have called the greatest generation, people who were born in the Depression and maybe fought in World War II, that generation was characterized by lots of things. One of them is sacrifice and service. And then later, things started to change. I'm not a historian by background in these specific elements, but I haven't seen anywhere that this notion is actually challenged. Where some of us are maybe old enough to remember who Gordon Gekko was in Wall Street. Greed is good, or the culture of narcissism. And Time magazine actually said that you were the person of the year back in the 2000s. If you think about the selfie stick, like at some point people became incessantly like posting about their lunch or something like that. But the selfie stick, if you think about it, is really weird. I mean, Dr. Nicholas Epley, who's a researcher at the University of Chicago, says that the selfie stick is the greatest totem to interpersonal misunderstanding, because the selfie stick is all about us. And perhaps the evidence actually suggests that that's not only not the best way to live, but actually can be associated with harm. If anybody here are fans of Freakonomics, our earlier book in healthcare actually was one of the episodes years ago on Freakonomics. But this is a more recent episode where they reviewed researchers that studied specific dimensions of national culture. And this is no political statement or anything like that. That's not my approach. But what they found in rigorous research by the people who are considered the most rigorous researchers in the world is that the U.S. is actually the most individualistic and self-focused nation in the world. They said by far. What I worry about a lot is this concept of me time, because we've gotten that message loud and clear that me time is important. I don't doubt that for a second. The question is, what comprises your me time? Because what the research shows, including this study from just a few years back, is that over time there have been very distinct trends in how people think of and execute on their me time and what they do. And what the research has shown is that people's me time activities have become more and more isolating. Again, put on your headphones and block out the world. Take a nature walk by yourself. Go do yoga. Nothing wrong with yoga, right? But things like we are going deeper with inward, right? How was it in decades past? When we were going through tough times, we found solace in family and in friends and in human connection, not in escape and detaching. And so, to some extent, I have concern about these trends. And I'm not suggesting cause and effect, because that really can't be tested for these data. But our trends are becoming more and more, it's all about meism, and less about serving others. And the data right now are staggering, not only for our physical health, because even when you take COVID out of the picture, the life expectancy in the U.S. is actually declining for the first time rather than going up, even when you account for COVID. And in terms of our well-being and our mental health, what people call, this isn't my term, but it's called the deaths of despair. So people who die by suicide, people who die related to drug use, people who die related to violence, these are all escalating at enormous clips. And so by the numbers, we collectively aren't doing very well as our me time gets more and more isolating. David Brooks of the New York Times, in his memoir, The Second Mountain, he framed it this way: rampant hyper-individualism of our current culture is a catastrophe. The current historical moment has normalized selfishness, self-preoccupation, leaving us divided and alienated. We are down in the valley. Thankfully, science shows we actually don't need to stay there. And so what Dr. Maz and I curated with 250 original science research papers is the benefits of serving others. And some of these things are pretty bold claims, like longer life and slower aging, but things that you may be familiar with, more strength and stamina because you feel energized when you're focused on helping and serving somebody you care about or somebody you just met for the first time.
And it's vitally important because I like to look at familiar things in unfamiliar ways and examine things that we typically view through a moral or ethical lens or emotional sentimental lens. And I try to view it through the lens of science. And one of the most important things with any scientific discipline is having common nomenclature. So what is compassion in the first place? So most researchers define compassion as an emotional response to another's pain or suffering involving an authentic desire to help. So it's distinctly different from a very closely related word, empathy. That's the sensing, feeling, detecting, and understanding another person's pain, suffering, or struggle. But compassion goes beyond empathy because it involves taking responsive action. So a really easy way to remember it is this: empathy plus action equals compassion. And these aren't just semantics. There are robust neuroscience data behind this distinction in terms. So using a brain imaging modality called functional MRI that can show us what part of the brain is being activated at any given moment in time, when you bear witness to pain and suffering and you have empathy for those people in suffering and struggle, it actually activates the pain center in your brain. And you know this experientially because it is so uncomfortable to watch people suffer. But what the same research modalities show is that when our minds are focused on serving, helping to alleviate a person's suffering or struggle and taking action in some way to help, that it activates a distinctly different part of our brain. It's not a pain center of the brain. It's what neuroscience researchers call a reward center of the brain, associated with positive emotion, positive affect, feelings of affiliation. It's part of the reason, and again, we all know this experientially, but it's part of the reason why it feels good to help people. So Dr. Maz, that's my colleague and co-author, Anthony Mazzarelli, we had to be very open to the possibility that compassion didn't really matter. So whenever you test a hypothesis, you must be agnostic to the hypothesis. So our hypothesis was that compassion matters, not just in meaningful ways, but also in measurable ways. And our approach to testing that hypothesis was systematic review. So we went through more than 1,000 scientific abstracts, over 280 original science research papers. And what we found was a very distinct signal in the data that compassion isn't just a nice to have, that it's actually vital to the quality of healthcare and vital to healing. So it makes measurable, not just meaningful, but measurable impacts on the quality of care. So it impacts patients and it also impacts those who care for patients. Not in just meaningful ways, but also in ways that can be measured. And there's evidence of a compassion crisis in society broadly. So really the question is it just spilling over into healthcare? And so the data support a compassion crisis more broadly. For example, a University of Michigan meta-analysis over 2 decades found that empathy among college-age students has been declining over time, and the speed of that decline is actually accelerating. A Harvard Graduate School of Education study of 10,000 youth, so these were middle school and high school students in the US, found that 80% of our youth believe that their parents value the kids' achievements and their accolades more than they value the kids' kindness for others. And in a striking Pew Research study from just a few years ago, fully 1/3 of Americans endorsed that they don't consider compassion for others to be among their core values that describes them well. But healthcare is supposed to be different. So I've always believed that compassion was a cornerstone of the art of medicine. But what Dr. Maz and I did in our work on compassionomics and our later work is we tested the hypothesis that compassion is not just in the art of medicine, but there are also evidence-based effects belonging in the science of medicine. So the question is, what is the evidence? And it's in the contemporaneously with the evidence that we actually have a compassion crisis in healthcare as well. So a Harvard Medical School study published in the journal Health Affairs found that 47% of Americans believe not only that our healthcare system isn't compassionate, but that our healthcare providers are not compassionate either. And in my domain, critical care, I'm an intensivist. So I'm a specialist in intensive care medicine. If you become my patient, it's because you need life-sustaining therapies in the ICU. We often meet people on what they consider to be one of the worst days of their life. And research from Johns Hopkins has found that 74% of interactions between the ICU care team and patients and families in the ICU is devoid of compassion. In fact, a University of Washington study has found that fully 1/3 of end-of-life conversations in the ICU, end of life, has zero expressions of compassion between the care team and the patients and families in the ICU, and that's at the end of life. So based on all these data and more, Dr. Maz and I conclude that we have a compassion crisis indeed. The question then, it begs a question, so what? I mean, does compassion really matter? And that was the launching off point for all of the work that we've done with Compassionomics. So we believe that there are three key components. And when I say we believe, it's actually not what we believe. It's not our opinion. It's not our feeling. It's just what we found in our journey through the scientific evidence. But there are three key components. One is realizing that there is, in fact, an evidence base for compassion. So it's not just a nice to have. And when you see the totality of the scientific evidence, that compassion makes measurable differences. You feel differently about your opportunity to treat patients with compassion. You feel like you're wielding something very powerful and very potent and something that's vital. Number two is believing that change is in fact possible. And I didn't always believe that. In fact, I thought that people were either wired for compassion or they're not. Like it's something that's in their DNA or they're not. But what the research clearly shows, not just in the healthcare domain, but broadly throughout the psychology literature, is that we can in fact get better at our behaviors in showing compassion to other people. And I am very much a work in progress. So that is good news for me indeed. And the last point is just realizing the time component, because, you know, we're very hurried now in healthcare, and we have been for some time now. But what the research shows quite clearly is that we just think treating people with compassion takes a lot of time. In the scientific studies that have actually measured compassionate behaviors that have had measurable impacts on patients, what the research shows, if we're going to be evidence-based about it, it's often less than a minute. In fact, one study from Johns Hopkins University shows that a meaningful compassion connection can be made in just 40 seconds. So I think it's all three of those things together. When you realize that compassion does belong in the domain of evidence-based medicine, there is an evidence base behind it, you realize that change is possible and we can actually work at our compassion and get better at it. And then realizing that it actually doesn't take much time. We just sometimes feel like it does. And once we overcome that cognitive bias, if you will, then that allows us to raise our game, so to speak, in compassion. So we have found that there are a total of 24 different mechanisms of action, so to speak, by which compassionate care can improve things in measurable ways. We bucket these 24 things into four different categories. One is physiological effects, one is psychological effects, one is patient self-care, how patients stick to the treatment regimen that's been prescribed for them, and then just on the quality of care. And so I'll start with the practical. So on quality of care, what the research shows, and I'll be summarizing now years of literature, in healthcare environments where there is less caring, patients are less safe. In healthcare environments where there is less caring, patients are less safe. And researchers have found this by studying a key component of the burnout syndrome, which we can talk about as well for effects on those who care for patients. But one of the key components of the burnout syndrome is depersonalization. That's an inability to make a personal connection. And depersonalization and compassion are not opposites, but I would argue that where there is depersonalization, there can be no compassion. Well, researchers have found that not just in hospital-based physicians, but also in surgeons, 8,000 surgeons from the American College of Surgeons, where there is moderate to high levels of depersonalization, there are higher levels of self-reported major medical or surgical errors. And from those data on association, we shouldn't infer causation because those study designs aren't made for that. But if your experience has been like mine, you've perhaps worked with people in the past who seem to not just care, they just don't care very much. And when you look at the meticulousness of their work or the lack thereof, sometimes it's just downright sloppy. But another practical element, and you mentioned diabetes, for example. So one of the key things in diabetes is adherence to treatment regimens. What the data show collectively is that when you care deeply about patients and they know that, they feel that, they are more likely to take their medicine. They are more likely to adhere to a prescribed treatment regimen. In fact, a study from 1,700 patients with HIV, this was conducted at Johns Hopkins University, they measured everything that they knew to be associated with adherence versus non-adherence to antiretroviral therapy to control HIV. Adherence is the key component of that treatment regimen. And what they found after adjusting the analyses for all the potential confounding variables like age and comorbid conditions and socioeconomic status and health literacy, they asked patients one question: does your HIV provider know you as a person? Know you as a person. And what they found after adjusting the analysis for all these different factors, that knowing the patient as a person was independently associated with a 33% higher odds of strict adherence to antiretroviral therapy, but that's not all. It was also independently associated with a 20% higher odds of having no detectable virus in the blood. Now, we don't infer causation from those study designs that show us association, but a causal pathway is not hard to imagine. So a patient feels known as a person. They trust their care team more. And so they stick to the plan. And it's not surprising to me at all that it clears virus from the blood. I think those are powerful data on the power of human connection. The best evidence for that is what you've experienced, right? You experience some healing in that moment, and no one can change that experience for you. And what I will tell you is that it's also evidence-based, because in the physiological domain, so that's one of our 4 buckets of effects on patients. There is robust research that the touch of a trusted other can actually attenuate a person's experience of pain. Now, I didn't say that compassion eliminates pain, because it doesn't do that. But what research in laboratory experiments and studies of experimentally induced pain, and don't ask me who volunteers for those studies because I have no idea, but both in those domains or in the laboratory environment as well as in clinical studies, post-operative pain, as you mentioned earlier, abdominal pain due to irritable bowel syndrome, patients with headache pain attending a migraine headache clinic, patients with low back pain undergoing physical therapy. There are clinical data as well. So the touch of a trusted other, and the key word is trust, the touch of a trusted other can have measurable effects. It's not magic. Like, I don't have any magical thinking. Now, you experience very striking, very quick symptom reduction. And I don't have any magical thinking, but what I can tell you is that the evidence lines up that that compassion from a trusted other can attenuate a person's experience of painful conditions. And that's been shown consistently over the years. So I think that hope gets a bad rap. You know, there are sayings in business like hope is not a strategy. Well, I think hope is necessary for every strategy, and including, getting through some of the difficult times in your life. I just finished curating the evidence, and it's actually more likely to be the topic of the next book, The Science of Hope. But there are 40 different papers that hope is associated with better outcomes for patients with cardiovascular disease, 30 different papers that show that hope is associated with better outcomes for patients that are diagnosed with cancer. And the list is very long and heterogeneous of conditions that can be affected by a person's hope. And hope is a belief. So rather than an emotion or a feeling, most researchers define hope this way. It is a belief that the future can be better than the present. So the future can be better than today. And I play a role in making it so. Which makes it different from a wish or just optimism, where I believe things will work out, but I just have no idea why. Hope is a bit different. And this goes all the way back to the early 1990s with something called hope theory. It's associated, there are three components. So hope has a goal or an aspiration, either an aversive one or a positive one, meaning like I hope that something doesn't happen, or I hope that something good does happen. And then pathways. Is there a pathway? Can we get there from here? Can we get to where that goal or aspiration is? And then the last part is what most researchers consider to be willpower or agency. It's one's ability to stay on the path, because the path is unlikely to be a straight line. There are going to be obstacles. And to what extent do you have the willpower, the agency to stay on that path even when the going gets hard? So there's a body of evidence that shows that hope matters, again, not just in meaningful ways, but in measurable ways. And again, I have no magical thinking about hope or compassion or any of this, because we examine it through a lens of science, and we've curated all the scientific evidence. So as they say, we brought the receipts.